Welcome to the University of Michigan Dentistry Podcast Series, promoting oral health care worldwide.
I'd like to introduce Dr. Jean-Pierre Joho from the University of Geneva, where he is chairman of the Department of Orthodontics and Pedodontics. I'd like to thank you for sitting in on this today, Jean-Pierre. I've known Jean-Pierre for probably 18 or 19 years, since he was a graduate student at the University of Washington. He, at that time, carried out a very extensive monkey study, and while I was doing my PhD, I also had the opportunity of meeting him at that time as well. Now, Jean-Pierre has a very unique background for European in the sense that he received a training in orthodontics at the University of Zurich, which is, when did you finish that?
In 69.
69. And then you went to the University of Washington?
Fall 69 for a regular program until fall 71.
Okay. Now, during your stay at the University of Washington, you had a very sort of a standard edgewise background, wouldn't you say? I don't mean standard edgewise in the sense of brackets, but just a very strong fixed appliance background.
Yes.
As opposed to the training?
As opposed to the very strongly removable background in Zurich.
Okay. Now, one of your special interests that I think is somewhat unique for an orthodontist is the fact that you've been interested in surgical sorts of techniques, surgical things, not maxillofacial surgery, but I guess as you term them, minor surgical procedures.
What I would like to call minor surgery, which, let's say, the surgery that is done by oral surgeons in the field of orthodontic treatments.
Okay.
Be it enucleation of third molar buds, be it extraction of supernumeraries before they erupt, be it get a hold on impacted canines, to put a button on to pull on, or whatever those, like frenectomies, and even the very simple procedures in serial extractions.
And these you would do because of your particular interest?
Well, I have particular interest, and during my residency in Zurich, I had a chance of doing, due to the staff that was there at that time, to do almost every surgery that was needed in the department, except maxillofacial surgery. To do this every morning from 8 to 10 was more or less surgery.
Okay.
And I would miss that. That's one point. And the other is that even in serial extraction cases, doing the surgery, the extractions myself, I'm not the bad guy who gives to the general practitioner only the bad work and the tear work. On the other hand, it's the chance of getting the patient's confidence when you're with the patient at his worst moments.
Now, we are going to talk today about one specific type of minor surgical procedure, and that is auto-transplantation of teeth as part of orthodontics. And first of all, I'd like you to define exactly what auto-transplantation means.
It is, in fact, a short term of autogenous transplantations. So, in other words, transplantations within the same mouth versus heterogeneous transplantation.
Now, how long has this, well, first of all, when did you start doing this type of procedure?
Personally, my first cases have been done in '76. But I've been introduced to by Sloxwold in '66 or '67, the time I was at the ortho department in Zurich, with Professor Hotz. And he did some demonstration. And then he published in the AJO very extensive work on auto-transplantations. And from then on, since they worked, whenever cases showed up that would allow to foresee transplantation, like when you have, let's say, congenitally missing bicuspids in 2 quadrants, both bicuspids missing in the 3rd quadrant and none missing in the 4th. So you switch from none missing to 2 missing, you transplant, and you get, like a serial extraction case, with 1 missing in every quadrant. So when those cases showed up, that they are not that infrequent, we started using the transplantation as a treatment tool.
Now, you've also used supernumerary teeth as a transplant. Is that correct?
Yes. Primarily in those situations where, by chance, supernumeraries were present, whereas through trauma, permanent ones had been knocked out or lost, or in a very rare case where there were supernumeraries beside congenitally missing ones, and then using the supernumeraries for the congenitally missing.
Now, I would suggest that many of the orthodontists have never used autotransplantation as part of their treatment regimen. And I think part of that reason is the fact of the fear of failure, the fear of losing teeth, having them rejected by the patient, creating larger defects than if you had done nothing. What kind of a success rate have you had, and what types of cases have you found work especially well, and what type of cases do you find do not work very well?
Well, to answer the first question, why orthodonts are hesitant? Probably because they don't have the necessary background of knowing what can be done in surgery. When you talk to oral surgeons, they are not that astonished that we do that.
Mm-hmm.
So they've known at least. And in fact, this technique should be brought back in mind to the oral surgeons. They would do it, but the orthodontists are not informed that it can be done. Now to the success rate, at this time we have, I think, 148 transplantations, and 2 failed. One was my mistake. I did not evaluate the X-ray of the transplant correctly. It was an upper second molar to be transplanted into the lower arch. The roots were too developed. We had to cut off roots, and it didn't work. As to the second question, the ideal moment is certainly when 1/4 to 1/3 of the root is radiologically visible. In other words, during root formation. And the ideal, with the less problems, transplants are the premolars.
Okay, so that I would suggest then that you would be saying a 10 or 11-year-old, 12-year-old child, 1/4 to 1/3 of the root.
Yes.
All right, now let us take a fictitious example, hypothetical example. And let's say that we had the case where you were going to transplant a presumably, obviously, unerupted second molar or second bicuspid into a place where there was no bicuspids on another quadrant. How would you do the procedure exactly? In other words, what steps, surgical steps, would you do? Do you take out the transplant first? Do you prepare the donor site? What is exactly the way that this is carried out?
Okay, let me maybe take an example which is more frequent than bicuspid to a bicuspid. Would be an impacted canine in a young adult or in a 16, 17-year-old. We would first mobilize the transplant. This is in all the transplantations where the transplant is difficult to get. First mobilize it and make absolutely sure you can get it out. Mm-hmm. Eventually take it out, measure root diameter and root length so that you know how large the artificial new alveolus has to be made. In your example of a bicuspid into another bicuspid site, we have to be very sure that the receiver site has a nice gingiva. In other words, we cannot take an upper second bi, which would have erupted a little bit early. Mm-hmm. We still have the deciduous molar in the lower where the premolar is missing. We should never plan to extract the deciduous molar and that in the same session get the premolar from the top down into because the socket would be so large that we cannot fit the gingiva tightly around the neck of the transplant.
Now, if you have a fully formed tooth that presumably still is not erupted. Let's use your example of the canine. It's my understanding that you will very often remove part of the root prior to moving it to the donor site. Is that correct?
This has come with the years. Because quite often when you have like upper cuspids, you have the total root length where you have to create a new alveolus. It is sometimes very long to go up there. And you're happy if you can knock off a part of it. In certain situations, I was forced to do it to get it up because vertically there was not enough space. And then suddenly, about 4 years ago, one of those cases, she was 17, 18. The patient showed 3-4 months later obliteration of the pulp chamber. So obviously this fully, completely formed canine root, cut off, had reanastomosed. And since then, for fully formed teeth with one root, we cut off about 1/3, trying to get this anastomosis. As an average, I'd say in 80 to 90% of the cases, endo is necessary.
And is the endodontics necessary at the time of transplantation, or is it necessary, let's say, a month or two later?
We do wait today at least 1 month. We go through the fixation period, which is about 3 weeks, where the tooth is, in any transplantation, is out of occlusion. And then in adult canines that were not clipped off, we do endo after 4 to 6 to 8 weeks. And now suddenly, as I said, since we got some cases where a clip off of the root allowed reanastomosis, we wait and sit back with endo doing X-ray control every 2 months.
Now let's talk a bit about the donor site itself. You just mentioned before that you like to make sure that the tooth is out of occlusion. Now, what's the reason for that? After you do the transplant?
Oh, this is just during the fixation period. We would like to have the tooth quiet without any traumatic occlusal trauma, so that the healing process around the tooth is...
Okay, and normally when you make a donor site, you make it slightly deeper than the tooth itself.
Yeah.
What's the reason for that?
Let's say if the root, the transplant of a premolar has a more carrot-shaped root, the alveolus will more be a pear-shaped alveolus, where the neck, where the transplant will be sitting in, will be slightly smaller in diameter than the transplant's diameter, and it will almost be wedged into place.
Okay. What percentage of teeth that you transplant become ankylosed?
This is hard to say in percentage. The only ankyloses we had were in adult canines. And there I'd say probably 1/4 to 1/3.
Now in those cases, do you purposefully put the tooth out of occlusion just slightly because let's say that it healed into that position and you couldn't move it no further?
No, the ankylosis in those cases showed up maybe 4, 6, 8 months after transplantation.
So that you can always move the teeth?
That's why we have now come down with our fixation period. In fact, we can start moving the transplants, especially in adults, as soon as the gingival healing around the neck, the attachment is...
And how long does that take?
10 days.
Oh, really?
To make sure. Before 10 days, you don't go with a probe.
Yeah.
But after 6 days, we take the sutures off. We see the patient another week later, so we're at 12, 14 days. We, at that time, usually change from rapid fixation, which was during the intervention with just a patch of concise, fixing the transplant to a stabilizing arch wire, switch to a bracket and get the canine into the appliance or the transplant into
do you
the
put the
appliance.
bracket on the tooth, let's say the appointment before, or do you wait till the time of the procedure?
No, today we put the bracket only on after the tooth has been transplanted, everything has been sutured down. If the crown is in sufficient length in the mouth, that we can put the bracket correctly on. If not, we will use the arch wire, bend it so that it barely touches the transplant, and fix it just with a patch of concise.
Now, we've talked about the transplanting of canines and bicuspids. Perhaps one of the earliest ways that transplants were done was from third molars to first molars. You want to comment about the use of that technique?
Yes, I think this is the most common technique. It is not the easiest one. It is especially difficult to evaluate how much root formation the third-year molar should already have to be transplanted successfully. On the other hand, it is a transplantation which most often needs some orthodontics to reopen the space of the sixth that has been a little bit lost. On the other hand, it cannot be done if the sixth has been lost a long time ago, because if we got all this involution of the alveolar crest, then we can't transplant. Or we have to go put the transplant so deep that we are close to the mandibular canal.
Okay.
And then it wouldn't erupt. Maybe.
What other uses of autotransplantation can you envision as far as, or other experiences that you've had? We talked about supernumerary transplantation, and presumably that's for like lateral incisors in that sense. Yeah. We've talked about canines, impacted canines. We've talked about bicuspids, in which there might be two in one arch and none in another quadrant, and molars. How about lower incisors? Do you ever transplant those anywhere?
We had one case to be used in a lower crowding, upper lateral missing, and the Bolton situation allowed or almost made it necessary to extract the lower incisor. And in order to replace the upper lateral, instead of throwing it away, we used it as a transplant. But I don't see quite often a lower incisor used as a transplant. But indications for transplantations are, of course, mostly when very abnormal, congenitally missing situations, or due to traumatism, loss of many units, and then you're faced with either large bridge work, and if you can get transplants in, even as bridge abutments, rather than implants, I think it's worthwhile.
Have you ever replaced central incisors in cases where you don't happen to have a convenient supernumerary? What do you use if, let's say, somebody traumatically loses centrals or has very misshapen central incisors in the upper? What kind of transplantation could you do there?
Well, if within the same mouth you have a, let's say, serial extraction condition in other quadrants, we've done using premolars as centrals, as in fact Slogswold published it already. If it's the ideal transplant for a central is probably the lower first bye. So if you have serial extraction situation in the lower, then you can use those lower first byes as centrals. If for any reasons you have to take an upper bye or two upper byes, you should then put them in rotation.
You mean 90 degrees?
90 degrees to give them the oval-shaped configuration. Because the big advantage of almost putting any transplant up into this upper incisor area is that when you have a root in there, you will not have the involution and resorption of the alveolar crest.
Now, when you are actually doing a transplantation procedure, and during the 10 days or however long that it takes before things get quieted down, is there a lot of discomfort for the patient?
No, it's amazingly little discomfort, except upper impacted canines that were palatally. Those are usually the most uncomfortable healing areas, I mean, where the patient has to go through a healing period. We advise to have absolutely a good fitting Holly we can put in just after surgery to avoid dehiscence of the palatal flap. But beside that, I mean, creating a new alveolar is apparently not a big trauma for a child. Like when we transplant the regular premolar transplantation sequence at an age of 12 approximately, the extraction is not a trauma because those premolars with only 1/3, 1/4 of the root visible, they come out like butter. Creating the new alveolar in those, even the compact layer is thin, and then you get into the spongiosa, and with, you know, twisting 2-3 times with your burr, you got your alveolar.
What do you use a round burr or something of that sort?
We use a round burr under water spray, physiologic water spray.
How about medications? Do you put the patient on antibiotics?
We don't have any pre-medication. It is all done under local anesthesia. And we have them for 4 days on antibiotics, plus rinsing with chlorhexidine solution, we call as this, plaque out.
Do you have any difficulty in, let's say, when you're suggesting this to a patient, have the patient or his or her parents, are they enthusiastic about this, or is it very hard to convince them about surgery like it is any other surgery? What's your approach?
Well, most of the time, the treatment plan will be done at the moment I explain the whole situation. And then they get the first shock, which is your child is missing 2 premolars in 1 quadrant. And that usually means bridge work, and then that's bridge work all your life. And you can say you start out with a 3-unit bridge at the age of 19, 20, and every 10 years you add 2 units. So at the age of 40, 50, you've got a full bridge. Whereas, since it is an extraction case, and there in 1 quadrant there is a premolar, I mean, both premolars are there, we can take this premolar instead of throwing it away and put it in. So psychologically, you can handle the parents relatively easy. In adult patients, it's even easier, because we can never promise it will work, but we can now, from our results, say we have a 95% chance. On the other hand, even if the transplant would stay in 4 or 5 years only, that's 4 or 5 years without a bridge, like in impacted canines. And in addition, like impacted canines where bridge work should be done, legally the impacted canine has to be taken out before we do the bridge work.
Right.
So we tell them, you go through surgery anyway. The bad surgery is to get it out. If at the same time we make a new alveolus and put it in, it doesn't take more than half an hour more in the total procedure. And a month from now, we already know if it's worthwhile, or 2 months from now. And by our material, we can show you have a very good chance of avoiding the bridge.
What's the gingival margin look like on these teeth?
In all patients still growing with still a lot of tooth eruption, let's say until 15, we don't have any problem with the gingival margin. In some adult canines, we got some dehiscences, but not such that we had to extract the canine.
I think we've pretty well covered most of the topics that I wanted to discuss. Is there anything else about this that you would like to bring up that we haven't covered?
Well, I would like, if ever this message gets out to some groups or so, I'd like to just let everybody know that it can be done, and that maybe we should inform our orthodontic community better about that it can be done, and then reinforce the procedures and how it should be done with the oral surgeons, at least in your country where the tasks are divided.
Right.
But I was not able, and I didn't want to publish anything before I didn't have enough observation time.
Mm-hmm.
Because I think it is not a procedure that should be advertised as very easy and everyone can do it. It should be done by somebody who has surgery experience, definitely. But the indication of doing it and what tooth and at what time, it's not the oral surgeon who sees those patients. It has to be the orthodontist. Mm-hmm. And knowing that this is a possibility, you know, I think when sometimes I present this material, 2 or 3 colleagues later on sent me case. Could this be the case for a transplantation? It's a patient I've never really knew what I should do. Mm-hmm. Now I've heard you, would this be possible? And with this, in fact, that's the way we got so many transplantations done, because they were sent to Geneva to be done a little bit from all over after the colleagues had heard that
Sure.
it was possible.
How difficult do you think the surgery is? I mean, should any oral surgeon be able to handle this kind of procedure?
Absolutely. But it has to be an oral surgeon who has a feeling for perio problems. In certain offices, it might even be better the periodontist does it, because he's so used to exact gingival surgery. Because that's one of the, maybe within the procedures, is to get your gingival so well adapted to the transplant and so well sutured to the transplant that avoids the most of the infections.
Okay.
It needs good surgery.
Anything else?
Yes, we hoped about 3-4 years ago, so around 84, that this could be developed further and preparing hetero-transplantation banks. Because with some cryo procedures, you would be able to, whenever a case is an extraction case, instead of throwing the tooth buds away, you could cryopreserve them, and then at any time for that patient, use it as a transplant again. If he would lose a tooth somewhere and would need a bridge, you could take, when he's 35, take his bud we took out at 12 and warm it up and use it. Now this has already been done and is possible, but what we then wanted to do was the hetero bank, using teeth we extract and keep them as a transplant bank for other patients needing transplantations or needing units to be replaced. Now I think with the entire AIDS story, everything that's on transplantation has been lowered down quite a bit.
That's an interesting sidelight I hadn't really thought about.
Yeah.
Well, thank you very much. I guess you talked earlier about some of the earliest references being over 200 years ago to this
That's
procedure.
right. John Hunter, 1777. Already talked about transplantations.
Well, I guess there's nothing new under the sun, but certainly this is certainly a very interesting aspect of orthodontics that I don't think too many people have inspected, and I thank you very much for your contribution today.
You're all welcome. It was nice to be here.
Okay.
Listening to a presentation from the University of Michigan School of Dentistry, which is dedicated to supporting open learning and open educational resources. This recording is licensed under the Creative Commons. It may be reused and redistributed for nonprofit use. Please attribute materials to the University of Michigan School of Dentistry and redistribute under this same license. For more information on how this and other University of Michigan School of Dentistry recordings may be used, visit www.dent.umich.edu/license.